recording's on, ma. Bhargavi, you can start, ma.
Okay, ma'am. A very good evening and heartily welcome to all. I'm Bhargavi. Take the privilege in comparing Health Phase 2K22, organized by DORAI Foundation in collaboration with the Department of Nutrition, Food Service Management and Dietetics from Srimati Devkanwar, Nananalbat Vaishnav College for Women, Crumpet, and Indian Dietetic Association, Chennai Chapter. The liver is often considered the nutritional gatekeeper of the body. It is the only organ capable of all major metabolic pathway in protein, carbohydrate, and lipid metabolism. Though careful regulation, it maintains a constant supply of the energy for the body to do work, whether fed, fasted, or starving. It synthesizes important proteins such as albumin, clotting factors, and transaminases, just to name a few. It is involved in vitamin and mineral metabolism, including vitamin B12 and D, pantothenic acid, and iron. Finally, it metabolizes drugs and clears chemicals such as alcohol and ammonia from the blood. The liver's failure to carry out these functions has a detrimental effect on the body's hemostasis. Each time your liver is injured, whether by disease, excessive alcohol consumption, or another cause, it tries to repair itself. And cirrhosis is a late stage of scarring, that is fibrosis of the liver. As cirrhosis progresses, more and more scar tissues forms and making it difficult for the liver to function. Advanced cirrhosis is life-threatening. To know more about liver cirrhosis, let's connect with our eminent speaker of the day, Dr. B. Bhavani ma'am, dietitian at ESIC Medical College Hospital, Union Ministry of L&E, Government of India. Our guest of honor for today, Dr. B. Bhavani ma'am, is a person with dynamic personality. Ma'am is an General Secretary and a representative of registered dietitian in the Indian Dietetic Association, Chennai Chapter. Madam is also a member of Board of Studies in University of Madras. Madam is currently working as a dietitian in ESIC Medical College and Hospital, Union Ministry of Labour and Employment, Government of India. She has also held reputed position in Indian Dietetic Association, Chennai Chapter between 2011 to 2018. Madam is a member of various reputed national organizations associated with nutrition. Dr. Bhavani has earned her UG degree in Nutrition, Food Service Management and Dietetics from Anna Adarsh College for Women. It gives me an immense pleasure to tell you all that Madam was a university rank holder at her post-graduation level, which she completed from Ethiraj College for Women. She had finished her registered dietitian internship at Madras Medical College and Government General Hospital. Having received her doctoral degree from Bharatiya University, Coimbatore, Madam specialized in food and nutrition. Dr. Bhavani was conferred the award of Best Public Health Nutritionist in India by the Indian Association for Parental and Eternal Nutrition (IAPEN), which added her feather in her cap. She has organized and participated in numerous awareness programs, national and international conference and workshop based on nutritional education. She has several publications to her credits. Madam is a disseminator of nutrition knowledge through television and print media as well. I deem it an honor to welcome our guest speaker of the day, Dr. B. Bhavani ma'am. Over to you, ma'am.
Good evening, one and all. Thank you, Ms. Bhargavi, for a warm introduction. A very good evening to one and all. I would like to thank the management principal of SNDP Vaishnava College, HOD Madam, and the faculties of the Department of Nutrition for providing me this beautiful opportunity. So, shall I move for the topic, ma'am?
Yes, ma'am. Yes, ma'am.
So the topic for the day is cirrhotic liver. Please share the slides, ma'am. Slides, please. Next one. Yes. So before moving into the medical nutrition therapy of the liver, we must first know the introduction about the liver. So liver is the largest internal organ, and the adult liver weighs about 1.5 kgs. So liver is generally situated under the rib cage and in the right side of the abdomen. The liver is a cone-shaped structure and it is dark reddish brown in color. The liver consists of two main lobes, left lobe and the right lobe. So both the lobes consist of small lobules, thousands of small lobules. These small lobules are nothing but small lobes. So these lobules are connected to a small duct. Duct is a tube-like structure. So these ducts are in turn connected to a larger duct, and these larger ducts form a common hepatic duct. So these common hepatic duct helps to transport the bile from the liver to the gallbladder and the small intestine. So what is a bile? So bile is a yellow liquid which is secreted in the liver, and this helps in the lipid metabolism. So whenever the liver function is disturbed, the bile production is also disturbed and leading to fat malabsorption. Next slide, ma'am. So there are many functions of liver. So liver majorly involved in metabolism, degradation, storage and synthesis. So the major function is metabolism. It involves in carbohydrate, protein and fat metabolism. So in a simpler term, what is genesis? Genesis is synthesis and lysis is breakdown. So it involves in carbohydrate metabolism like gluconeogenesis, glycogenesis and glycogenolysis. So what is gluconeogenesis? As the name implies, this is synthesis of glucose from non-carbohydrate sources like protein and fat. And next is glycogenesis. What is glycogenesis? Synthesis of glycogen. So the excess glucose is converted into glycogen and stored in the liver. So it is used for the future usage. And next is glycogen lysis. Glycogen lysis is breakdown of glycogen. That is, when the body is starving for glucose, the stored glycogen is broken down to glucose and it is used as the energy. So these are the carbohydrate metabolism. And it's moving on to the lipid metabolism. So the liver helps in cholesterol synthesis and lipogenesis. Lipogenesis is nothing but lipid synthesis. It is also involved in the protein metabolism. So next function is degradation. So this is very, very important function of the liver. So whenever the liver function is disturbed, this degradation or intoxication or elimination process is also disturbed because the liver helps to degrade or excrete or eliminate all the toxic substances and unwanted drugs. For example, drugs such as paracetamol. When a person consumes excess of paracetamol, then required, all these excess drugs are excreted via the liver. Even the ammonia. Ammonia is an end product of protein metabolism. So this excess ammonia, generally the ammonia is excreted via the liver. So when liver function is disturbed, what happens? Ammonia is not excreted in the liver and it gets accumulated, leading to hepatic encephalopathy. We will see about hepatic encephalopathy in upcoming slides. And next is bilirubin excretion also. What is bilirubin? Bilirubin is a pigment and which is forms when by the breakdown of red blood cells. So bilirubin is an indicator of jaundice. So when excess of serum bilirubin is present, it is an indication of jaundice. So all these products are degraded or eliminated via the liver. The next important function is storage. So most of the vitamins and minerals are stored in the liver. And then synthesis. So liver helps to synthesis many nutrients and compounds. I have already said about the bile. Bile is a pigment which is it's a fluid. It is secreted by the liver and it helps in fat absorption. And next is the coagulation factor, which is essential for blood clotting. And then Serum albumin. So serum albumin is also, it's a type of protein which is synthesized in the liver, and serum albumin is an important indicator for malnutrition. And C-reactive protein, this is a protein which is a good indicator for to know the rate of infection. So when a person has been infected with any viral or bacterial condition, the C-reactive protein test is taken. So this is a very good indicator for infection. And then the carrier proteins, and many hormones are also synthesized in the liver. So what is carrier protein? So there are a number of carrier proteins. For example, ceruloplasmin, transferrin, all these are synthesized in the liver. So these transferrin is a carrier protein for iron, ceruloplasmin for copper. All these helps in the functions of these nutrients. So all these compounds and carrier proteins are synthesized in the liver. So these are the many functions of liver. So when these functions, when liver is not functioning properly, all these functions carried out by the liver is very much disturbed, leading to many dysfunctions. Next slide, huh? So these are the common conditions we can able to see, like fatty liver, cirrhosis, hepatitis, hepatic encephalopathy, Wilson disease, etc. So when the liver transplantation is the last stage where the liver undergoes liver failure, and liver transplantation has been done. Next slide. Okay. Before entering into the medical nutrition therapy of liver diseases, the most important is nutrition assessment. So nutrition care process consists of 4 steps: nutrition assessment, nutrition diagnosis, nutrition intervention. The only in 3rd step nutrition intervention is coming, and the 4th step is nutrition monitoring and re-evaluation. So these are the 4 steps which has to be taken care, or which has to be carried out by a nutritionist before taking up the medical nutrition therapy. Without nutrition assessment, the nutrition therapy is absolutely incomplete. So the first step in medical care or nutrition care is nutrition assessment. So in nutrition assessment, what we do, that is the first step, nutrition assessment. So we generally use ABCD methods. So what are the ABCD methods? A is anthropometric, B is biochemical, C is clinical, and D is dietary. So in anthropometric method, we generally, so the basic simple is we must check their height and weight. So with the help of the height and weight, we can calculate their BMI. With measuring their waist circumference and hip circumference, we can measure the waist to hip ratio. And then we can use the calipers to assess their mid-upper arm circumference, mid-arm circumference, also the skin fold thickness. All these measurements can be carried out using calipers. So all these are anthropometric measurements. And next is biochemical. So as a nutritionist, it is very essential to know the biochemical parameters and biochemical reference ranges also. So when you undergo intervention for a patient, you must know all the glycemic profiles. I mean, you must know all the biochemical parameters such as glycemic profile, which includes fasting, postprandial, and HbA1c, lipid profile like total cholesterol, LDL, HDL, VLDL, triglycerides, etc., liver function tests like SGOT, SGPT, and then even thyroid profile such as T3, T4, TSH, etc. And then other parameters like nutritional indicators such as serum albumin, serum globulin, total protein. All the parameters must be analyzed. So you must check before checking the patient, you must check all the biochemical parameters. So with the help of biochemical parameters, you can assess their condition. You can help out the patient with their requirements. So this is biochemical. And what is clinical? So you can, from viewing the patient, you can able to know whether the patient is having any deficiency or not. So from head to toe, you must do a clinical evaluation. For example, for paleness, what is the manifestation for paleness? Manifestation for anemia, paleness, pale skin. All these are the manifestations for anemia. So in such a way, you must know all the clinical symptoms also, and you must correlate with the nutritional indicators. So that is about the clinical. And dietary, which is essential for every nutritionist. Dietary involves food frequency questionnaire and 3-day dietary record. So all these parameters must be carried out. Apart from the 3-day dietary record and food frequency questionnaire, you must have a basic questionnaire which consists of the patient's likes, dislikes, if he is having any appetite, loss of appetite, if the patient is anorexic, if the patient is having any vomiting, nausea, diarrhea, constipation, if he or she is having any food allergy, if he or she is taking any supplements or nutritional supplements, all such details has to be taken down by the nutritionist before doing the intervention. So all these are ABCD methods. Generally, we use all these ABCD methods. Apart from ABCD methods, now the nutrition fraternity or the nutrition body has too many using nutritional tools. Like for example, we have MUST, Malnutrition Universal Screening Tool. Then we have MST, we have SGA, we have S3PG, we have MNA. So all these are the nutritional tools. So by using all these nutritional tools, you can able to assess a patient nutritional status. So you can able to know whether the patient is well nourished, malnourished, or does he require any additional nutritional support also. So you can able to find out. So apart from all these ABCD methods, you must also use the nutritional tools. Next slide now. So in case of liver, in case of exclusive for liver patient, there is one particular nutritional tool is used, that is Royal Free Hospital Nutrition Prioritizing Tool. This particular nutrition tool is used exclusive for the liver patient to know whether the patient is malnourished, well-nourished or undernourished. Does he require any special nutritional therapy? Next. So this is I have shared the nutritional tool. You can take it later. Next slide. So today my topic, what I have been given is cirrhotic liver, but without touching about fatty liver or without talking something about fatty liver, we cannot get into cirrhotic liver because the fatty liver is the root cause of cirrhotic liver. So fatty liver is very most common liver condition in many of the hospitals. So I'm just starting with fatty liver. So you can able to see the liver. The normal liver is reddish brown in color, whereas the fatty liver is yellow in color because the color of the fat is yellow. So you can able to see the fatty liver and the normal liver. So what is fatty liver? In a very simpler term, fatty liver is a condition where fat accumulates in the liver. Fat accumulation in the liver. It is also otherwise called as hepatic steatosis. Hepatic, the term hepatic means liver, steatosis means accumulation of fats in simpler terms. So basically the fatty liver is classified into two, Nafl and Afl. That is non-alcoholic fatty liver disease and alcoholic fatty liver disease. So as the name implies, non-alcoholic fatty liver means fatty liver occurs not due to consumption of excess alcohol, whereas alcoholic fatty liver means fatty liver due to excess of alcohol consumption. Okay. So this non-alcoholic fatty liver disease has been once again classified into two conditions: non-alcoholic fatty liver (NAFL) and non-alcoholic steatohepatitis (NASH). Please just check the terms. The first one is non-alcoholic fatty liver disease (NAFL). So this has been classified into NAFL and NASH. Non-alcoholic fatty liver and non-alcoholic steatohepatitis. And the other one is alcoholic fatty liver or NASH. So, next slide please. Yes. So, in simpler term, this NAFL, this NASH is progress to cirrhosis. Then this ASH, alcoholic fatty liver, also progress to cirrhosis, whereas this NAFL is reversible. Non-alcoholic fatty liver is reversible, whereas NASH gets progress to cirrhosis, and even ASH, alcoholic steatohepatitis, also gets progress to cirrhosis or cirrhotic liver. So what is Nafl? As I said, it's an accumulation of fat. More than 5% of the total liver weight. If more than 5% of total liver weight is accumulated with fat, then it is called as Nafl. So what are the causes for Nafl? Mainly it's overweight or obesity, and then insulin resistance, and then consumption of high-calorie diet, consumption of refined foodstuffs, and hypertriglyceridemia. This is very, very important. It's actually a very good hint. So whenever your patient comes with raised fasting glucose level, it is one of the indicator that the patient might get into fatty liver. Even this is about non-alcoholic fatty liver. So hypertriglyceridemia or raised triglycerides level is one of the indicator for fatty liver. So these are the manifestations. Mild is sort of body pain, and then fatigue, then right upper abdomen pain, and hepatomegaly. What is hepatomegaly? That is enlargement of the liver. So all these are the manifestations. And what are the associated risk factors? When the patient is having PCOS in case of female, and sleep apnea, hypothyroidism, or involved with or associated with fatty liver. So then what are the interventions? Pharmacotherapy, LSM, and bariatric surgery. Pharmacotherapy involves the drugs, and lifestyle modification involves nutrition, diet, and exercise, and bariatric surgery. So when the patient is overweight or even the patient is obese, when he requires bariatric surgery, and then only bariatric surgery is suggested. Next slide, please. So the first intervention, medical or nutrition intervention, is weight management, because most of the fatty liver patients are obese, and many research shows that reduction of the body weight helps to reduce the fatty liver or the accumulation of fat in the liver. So about 5 to 10% of weight reduction is always should be targeted. And then hypocaloric diet. So how can you reach that weight management? Only by consuming hypocaloric diet. So you must cut down the caloric. If the patient is overweight, this is only in case of overweight and obese patient, and not in case of underweight patients. So that is the reason why we must go for nutritional assessment. If the patient is underweight, no need to cut down the calorie. If the patient is overweight or obese or pre-overweight also, about 23 kilogram per meter square, up till 23 kilogram per meter square, there is no BMI, there is no need to cut down the calories. But if it is more than 24, you can go for cutting down the total calories. So hypocaloric diet or low caloric diet can be given. But if you want to reduce, for example, if the patient is overweight or obese, and if you want to reduce the patient's weight, how much you can reduce? There is always a question: how much weight you can reduce per month or per week? It's always 0.5 kg to 1 kg per week. That is only 2 to 4 kgs per month. So that is the only all the nutrition guidelines says only 2 to 4 kg reduction per month. So this is according to all the nutrition guidelines. So there are many quacks and many fake propaganda is there, like in reducing 10 kgs or 15 kgs in a month or 2 months. That is all. No, that is not at all possible, and that is not good. So the proper weight reduction practice is maximum 2 to 4 kgs of weight reduction per month. That is half a kg to 1 kg per month. Per week is the right one. So that is based on the scientific based evidence. So for following this weight reduction, you must go for complex carbohydrate. So avoid all the simpler stuffs and avoid the refined carbohydrates, because all these refined carbohydrates increases your hypertriglyceridemia or increases your triglycerides level, which again increases your fatty liver. And in the other side, these refined sugar also increases your fasting blood sugar and makes you to become a diabetic. So this is always essential to reduce or cut down your refined carbohydrate and go for a complex carbohydrate. and avoid all the sucrose and fructose rich foodstuffs. Next slide, please. So if it comes to protein, protein is based on the RT in case of fatty liver. There is no restriction for protein in case of fatty liver. Overall in liver disease, there is no restriction for protein, because in earlier days there was a myth like protein has to be restricted in many liver conditions like hepatic encephalopathy or even in case of cirrhosis. But at present, there is no recommendation to restrict the protein. In fact, it's an high protein, normal to high protein only. Protein has to be restricted only in case of hepatorenal condition. That is when the patient is also having some kind of renal dysfunction. Only in such cases, protein has to be restricted. Otherwise, there is no need for restricting the protein. So in this case, in case of fatty liver, protein is normal protein, that is 15 to 20% of the total calories should come from the protein, and fat is about 20 to 30% from the total energy, and then among them 5 to 10% from PUFA polyunsaturated fatty acids, and 15 to 25% from PUFA monounsaturated fatty acids, and only 7 to 10% from the saturated fat. It should not go beyond 10%. Okay, and then avoid all the trans fatty acids and all the junk foods. Next slide, please. So this is the dietary management. So you can, the main purpose is low fat diet. So already the fat is accumulated with the liver is accumulated with the fat. So avoid fat. So that is the only major criteria. So you can go for boiled, steamed, baked foods, no fried items. And there is a study which shows that vitamin E can be supplemented. That is about 800 international units of vitamin E in the form of alpha tocopherol can be prescribed. So that you can also take 30 grams of walnuts every day. So you can go for antioxidant rich foods. You can take all yellow, green, orange rich foods to provide all your antioxidants. And the most important is eat smaller and frequent meals. About 4 to 6 small meals also can be taken. Okay, that is very important. Increase the chew count. Eat very, very slowly. Just it should be a mindful eating. Cherish your food. Eat slowly and increase the chew count. And consume all the plant-based foodstuffs, because the advantage of plant-based foodstuffs are it is rich in fiber, it is rich in antioxidants and low in fat. That's the reason why we prefer plant-based foods. And you can consume fish for 2 to 3 times per week, because it is rich in omega-3 fatty acids. And probiotics, prebiotics is also recommended. And then because it improves the liver function, and DASH diet is recommended. What is DASH diet? Dietary approaches to stop hypertension. This DASH diet is recommended for hypertensive patients. But this is also recommended for our fatty liver patient. Why? That's the reason is generally in DASH we restrict the sodium. We give them a low-fat diet and we give them more of fiber. So that's the reason why we recommend DASH diet. And then a few studies also shows that aronia extract or aronia juice also helps in fatty liver. Next slide, please. So these are the foodstuffs which has to be avoided. All the sucrose and fructose rich beverages, sweetened beverages, soft drinks, processed food, red meat, fried foods, fast foods. And then monosodium glutamate, or in simpler terms Ajinomoto, has to be avoided, because very simple, in simple term, for fatty liver, restrict simple sugars and restrict fat. Next slide, please. So you can consume variety of foods. So when the patient is a fatty liver, not only in case of fatty liver, in case of any condition, encourage your patient to consume locally, seasonally, and freshly available foodstuffs. It should be a variety of foodstuffs. And then no alcohol, strictly no alcohol, even though it is NASH, non-alcoholic fatty liver. Even the recommendations shows to take some amount of alcohol, you encourage your patient not to take alcohol because alcohol in turn increases your weight, your body weight, which may lead to other comorbidities. So the very important is split your meals. So instead of taking 3 large meals, you can go for 6 meals, small and frequent meals. So that is very important. And then consume more fruits and vegetables and everything. Next slide, please. Then this is next is enteral nutrition. So the mode of feeding. You know, there are 3 modes of feeding. It's oral, through mouth, and then tube feeding, and next is the total parenteral nutrition via veins. So if the patient is not able to take orally via mouth, he can go for enteral feeds or parenteral feeds. So in case of enteral nutrition, generally you can prescribe up to 30 calorie per kg body weight. In case of obese patient, you can give them 25 kilocalorie per ideal body weight. And in case of protein, 2 to 2.5 grams per kg ideal body weight is recommended. This is what I have said. Alcohol intake, don't recommend or prescribe your patient to take alcohol even in a smaller quantity, even though the guideline says 30 grams per day for men and 20 grams per day for women. Next slide, please. And physical activity, it is very, very important to undergo physical activities. According to American Diabetes Association, 30 minutes of walking or any kind of physical activity has to be performed for at least 5 days in a week. It can be a brisk walking or a stationary cycling, jogging or anything. So you must reduce the time spent in sedentary activity, make the person mobile, ask him to move around, so that this helps to reduce the fat accumulation. Next slide, please. So next is non-alcoholic steatohepatitis. So again, the manifestations are same: nausea, vomiting, fatigue. All manifestations are very common. Again, intervention: avoid the triglycerides, maintain a healthy body weight, blood sugar. I mean, the medical nutrition therapy is almost similar for NASH. Next slide, please. Then alcoholic fatty liver. Alcoholic fatty liver, this gets progressed to the next stage, cirrhotic liver. So it has 3 steps, 3 stages: alcoholic fatty liver disease, alcoholic hepatitis, and cirrhosis. The last stage is cirrhosis. So, as alcoholic fatty liver disease, excess of fat accumulation due to excess of alcohol consumption. Then alcoholic hepatitis, inflammation of the liver, and cirrhosis. You know, the liver cells gets scarred, and this is not at all reversible. Next slide, please. So this is the medical nutrition therapy for alcoholic liver disease. So it's generally, if the malnutrition and sarcopenia is very common among alcoholic liver disease. So in case of NASH or Nafl in earlier stages, so overweight is one of the cause. But in case of ASH, due to excess consumption of alcohol and due to liver dysfunction and improper liver nutrition metabolism, malnutrition and sarcopenia is very common. So you're going to increase the calorie content and protein content according to the BMI. So protein may go up to 1.2 to 1.5 grams per day. And fat is less than 25%, and absolutely reduces saturated fat. And micronutrient deficiencies are very common. You must need to supplement these patients with the micronutrient. Next slide, please. Next slide. So this is the dietary guidelines: consume whole fruits, vegetables, no saturated fat, no sugary items, no processed items, less salts, and encouraged with physical activity. Ask them to consume all these seeds, because seeds are rich in omega-3, omega-6 fatty acids. So no refined carbs, only complex carbohydrate is recommended. Next slides, please. Next slide. So coming to the major part of the day. cirrhotic liver. So I have already said alcoholic liver disease gets progressed to cirrhotic liver. We can look into the picture stages of liver. The first picture is healthy liver, which is red in color. So when the fat gets accumulated, fat liver is formed, and after that fibrosis, that liver gets fibrosis, and then final stage is cirrhosis. Cirrhosis is nothing but the tissues are scarred. That is, it is a late stage or last stage of liver disease. In cirrhotic liver, the healthy tissues is replaced with the scarred tissue. So, in case of healthy tissue, it helps in blood flow and normal function of the liver. But what the scar tissue will do, in the scar tissue will block the blood flow and leading to which disturbs the regular or normal functions of the liver and also raises the blood pressure. That's the reason why liver patients or cirrhotic patients have raised blood pressure. So the scar tissue block the blood flow, which leading to raised blood pressure, and also the other liver functions is also disturbed in this case. Next slide, please. So what are the causes for etiology of cirrhosis, cirrhotic liver? So major causes, alcoholic, as I said, alcoholic related liver disease, excess consumption of alcohol or alcoholic fatty liver ends up in cirrhotic liver, and then even chronic hepatitis B, chronic hepatitis C, and autoimmune hepatitis, and sometimes non-alcoholic fatty liver also may progress to cirrhosis. And some hereditary disorders and bile duct disorders are the causes for this cirrhotic liver. Next slide, please. So these are the symptoms, manifestations. There are a number of manifestations involved associated with the liver cirrhotic. So it's not only liver. When a patient is affected with the cirrhotic liver, only the abdomen portion or the liver is not only affected. Generally, the manifestations are from head to toe. All the major organs are also affected. For example, in case of neurological area, hepatic encephalopathy is common. What is hepatic encephalopathy? The excess of ammonia. The toxins are accumulated in the brain, and then peripheral neuropathy, astraxis, everything is common. What is peripheral neuropathy? Is generally some kind of weakness, and then astraxis is when you extend your wrist, you may see some tremor. So tremor is seen when you extend your wrist. So that is that. And then many gastrointestinal symptoms are very common, like anorexia, vomiting, nausea, sometimes constipation, change in bowel habits, all this metamesis, that is blood vomiting, congestive gastritis. All these are very common in case of gastrointestinal disorders. And next is reproductive disorders, conditions like amenorrhea. What is amenorrhea? Absence of menstrual cycle in case of female. Then testicular atrophy. What is generally atrophy means? It's shrinking. So the meaning of atrophy is shrinking. So testicular atrophy is shrinking of the testicles in case of male, and then lympotency is seen in male, and then gynecomastia is seen in male. What is gynecomastia? That is enlargement or enlargement of breast in case of male. So that is about that. And then integumentary, that is skin conditions. All this jaundice, spider angioma, palmar erythema, purpura, everything is seen. All these are some kind of rashes seen. You can see the second picture. Second picture is spider angioma. You can see a red spot which looks like a spider. And the third picture is palmar erythema. So in your palm there is some red spots are seen in the palm. So that is that. And the first picture is purpura. Purpura is some dark red spots in the skin. So all these symptoms are skin conditions are seen in case of cirrhotic liver. Then hematological anemia, absolutely. That's the reason why I said you may see the biochemical parameters. So in biochemical parameters, you can come to know that all the CBC, total blood count, complete blood count with WBC, RBC, everything you may come to know, and with that you can able to do the medical nutrition intervention. So anemia is very common, thrombocytopenia, leukopenia, all splenomegaly. Splenomegaly is enlarged, megaly is enlargement, so enlargement of spleen, and coagulation disorders, everything is very common. And next is metabolic changes, so hypokalemia. So in most cirrhotic patient, potassium, low potassium is seen, low sodium is seen, low albumin is seen. So low serum albumin, low serum potassium, low serum sodium levels are seen in these patients. And cardiovascular problem, and then fluid retention. The most important manifestation of cirrhotic liver is ascites, that is fluid retention in these abdomen area. Ascites is very common. So all these are the general manifestations which are seen in the cirrhotic liver patient. Next slide please. So protein energy malnutrition is a very important condition seen in cirrhotic liver. Why protein energy malnutrition is seen in cirrhotic liver? Because due to long-term food restriction or whatever, the intake is very less, and then which leads to protein energy malnutrition. Because in case of cirrhotic liver, there is fluid retention is there, so we might reduce the fluid intake, sodium intake, everything. So when a salt is reduced in the food, the palatability of the food is also reduced. So due to that also, patients may refuse to consume food, which might lead to protein energy malnutrition. So poor oral intake due to anorexia. So anorexia is very common. So due to anorexia or some GI disturbances or nauseatic symptoms or vomiting, if oral intake gets reduced, thereby leads to protein energy malnutrition. And moreover, cirrhosis is an hypermetabolic state, and malabsorption is also very common, because when the liver function is disturbed, all the carbohydrate, protein and fat metabolism and other even micronutrient metabolism is also disturbed very badly. So because of that, malabsorption of fat is very common, so which may lead to protein energy malnutrition. So if you look at a cirrhotic patient, the patient will be very skinny and bony. The patient looks very thin actually. He may looks very malnourished. Next slide please. So moving to the medical nutrition therapy. So general dietary guidelines for cirrhotic liver is high calorie, high protein, low fat and low sodium. It's very simple. High calorie, high protein, low fat and low sodium. So high calorie, why high calorie? Already the patient is under patient is protein energy malnutrition. For that purpose, we must give him high protein and high calorie. So high calorie is recommended. Since the patient is having anorexia and vomiting, we must gradually increases his calorie. Okay, it's to prevent dumping syndrome. So we must gradually increases his calories. So you can give him 35 kilocalorie per kg body weight. In case of obese cirrhotic, you can give him 25 kilocalorie per kg body weight. And for a critically ill patient, you can give him 35 to 40 kilocalorie, whereas in case of pre and post-operative cirrhotic patient, 30 to 35 kilocalorie is recommended. For obese patients, strictly physical activity is recommended. Physical activity is generally recommended for all the patients, but strictly it has to be followed among obese patients. Next slide, please. Next slide. So coming to protein, so there is no rule or no any guidelines to restrict the protein, as I said earlier, only in case of hepatorenal condition. If the liver patient is having even renal problem, then only you must reduce the protein. Otherwise, there is no requirement to reduce the protein. So you can give him up to 1.5 kg per 1.5 kg. 1.5 grams of protein per kg body weight. That is generally it is 1 gram per kg body weight. So you can give up till 1.5 gram per kg body weight. And then protein restriction to prevent encephalopathy is not at all recommended. So you can give him plant-based sources and dairy protein, because plant sources and dairy sources are rich in BCAA, branched chain amino acid. This branched chain amino acid is recommended in case of cirrhotic liver. This helps to improve the appetite, increase the muscle synthesis. So BCAA can be given up to 4 grams per day of BCAA, branched chain amino acid like leucine, isoleucine, and valine can be given or recommended to these patients. For this purpose only, we are recommending plant and dairy source protein. And another advantage of plant protein is it is rich in, as I already said, it is rich in fiber, it is rich in antioxidants and low in fat. You can also give in some amount of animal protein. There is no rule that we must completely avoid animal protein. If patient wants to take animal protein, he can take some amount of animal protein also, but majorly concentrate on plant-based protein due to the presence of fiber, BCAA and antioxidants. Coming to the fat, absolutely it is low fat diet, no saturated fat, and you can give him PUFA and MUFA, no cholesterol rich foods. Give him MCT based foods. Because why MCT? Medium chain triglycerides, already the lipid malabsorption is there. For that purpose, we are giving the MCT. Since the fat is not absorbed properly in case of cirrhotic liver, we are recommending them with medium chain triglycerides, which does not require bile for absorption purpose. Okay. Next slide, please. We have already covered this. Next slide. So sodium, coming to the sodium. So the important manifestation of cirrhotic liver patient is ascites, that is a retention of fluid in the abdomen. So ascites is very, very common. So in this case, we must reduce the sodium content. So how much of sodium is recommended? 80 mmol or 2 grams of sodium or 5 grams of salt is recommended. That is 1 teaspoon, 1 small teaspoon. So 5 grams of salt is recommended, but ensure that it should not go below 60 mmol per day. So if it is less than 60 mmol, the palatability of the food is affected, which leads to reduction in the food intake of the patient, which may once again leads to protein energy malnutrition. So again, fluid is restricted. When fluid is restricted, when the patient is having ascites, the fluid is restricted. Otherwise, fluid is not restricted. And then zinc. Because cirrhotic liver patients are prone to anorexia, we are providing them or supplementing them with zinc. So 50 milligram of elemental zinc or 220 milligram of zinc sulfate is recommended. And calcium, this is very, very, very important, because due to fat malabsorption, fat soluble vitamins are also affected, because since fat is not malabsorbed, fat soluble vitamins are also malabsorbed, because fat soluble vitamins require fat for absorption purpose. So because of that, calcium is now also not absorbed properly, because calcium requires vitamin D for absorption, vitamin D requires fat for absorption. So it's all a vicious cycle. So calcium deficiency is very commonly seen in cirrhotic patient, which leads to bone disorders. For that purpose, we are supplementing them with 1000 to 1000 milligram of calcium per day to avoid bone disorders. So other fat soluble vitamins like D and K is also D and K is also supplemented. And in case of B complex deficiency, B1 thiamine is very, very, very common. Thiamine deficiency is very, very common among cirrhotic liver patients, because when during alcoholic intake, Burnett's encephalopathy is also very common. So B complex vitamin is deficiency is common. Not only B1, many other B complex is deficient. For example, folic acid also. This folic acid deficiency increases the blood homocysteine level. So homocysteine is amino acid. This homocysteine level is also raised, which in this raised homocysteine may leads to fibrosis and leads to cirrhosis. Thus, folic acid also to be supplemented. So generally, we are going to supplement the patient with zinc, with calcium, with vitamin D, vitamin K, and all the B complex vitamins, especially with folic acid. Next slide, please. So these are the dietary guidelines. So again, don't give him larger meals. Instead, give him small and frequent meals. That is, give him 6 to 8 meals per day. That is, small and frequent meals can be given. In every meal, protein has to be given, and the most important thing is late evening snack has to be given. So many nutrition body recommends late evening snack for the cirrhotic patient. That is, a late evening snack is between 9 p.m. to 11 p.m. With 500 kilocalorie and at least 50, minimum 50 grams of carbohydrate. So, for example, you can give them a handful of roasted Bengal gram puttu kadalai, and then you can give them 2 slices of bread with some nuts or chenas, and then you can give some nut bar. Then you can give them high energy and protein supplements. That is the nutrition, disease-specific nutrition formulas can be given. You can give them curd or yogurt with some bread or some nuts. So all these foodstuffs which are rich in both energy, both the carbohydrate and protein can be recommended between 9 to 11 p.m. And then encourage physical activity among the cirrhotic patient, as I said already. And then give them with high protein, energy, vitamins and minerals. You can give them some shakes, milkshakes. Like you can give him date milkshake, banana milkshakes, etc. So all these foodstuffs will increase the energy, protein and some vitamins also. So avoid salt, because sodium restriction is very, very important in case of ascites. So when you go for some salt substitute, just check the composition of the salt substitute also, because most of the salt substitute are also rich in potassium. So you just have a look at the composition. So we can go for a low potassium salt substitutes also. And then give him healthy foods with vegetables and fruits. Go for a variety of foods. Avoid processed pastries, and then preserved foods, fast foods, preserved meats, tin foods, etc. Next. Cirrhotic liver, it's CL means cirrhotic liver. Mode of feeding. So generally, as I already said, you can look into the picture. So it's generally the tube feeding is nasogastric, naso-jejunostomy feeds. So NJ feeds, that is the tube is inserted in the nose. So that tube will get enter into your jejunum or duodenum. So you can able to see that tube. So the other type of feed is peg feeds or ostomy feeds, gastrostomy or jejunostomy. That is, a small hole is inserted in your abdomen cavity, and the liquids are given through that small hole. That is called as gastrostomy feed or jejunostomy feeds. Okay, so when the patient is not able to take the food orally, then we go for enteral nutrition, that is through any ostomy feeds or tube feeding. So, but in case of GI bleeding, tube feeding is stopped until the bleeding stops. So that is the only contraindication. And then in case of peg feeding, that is via the abdomen, that peg feeding is contraindicated due to bleeding risk, infection and ascites. So whenever there is ascites, infection and bleeding risk, peg feeding is not used. Only tube feeding is used. When this enteral nutrition via either ostomy feed or tube feeding is not possible, then only we go to the parenteral nutrition or TPN. Okay. So next this is very important, strategies to avoid protein energy malnutrition in hospital. So all the cirrhotic liver patients who have been hospitalized or prone to malnutrition. So how can you reduce this malnutrition in these patients? So you can avoid or minimize the NPO in fat. What is NPO? It's nil per oral. That is, the patient won't be will not be given any food or liquid orally. So that is nil per oral. This patient is kept on nil per oral for few medical or surgical reasons. He may kept in NPO. So what you can do that at that time? So you must what? you can do is you can avoid or minimize this NPO time, and you can give them dextrose, intravenous dextrose during this NPO time. When the patient is on NPO, you can give him dextrose through intravenously. And then if the patient is taking oral foods, provide him with bedtime snacks and early morning snacks. So when early morning, instead of giving some coffee or tea, give him some energy drink with protein so that he can improve his nutrition level. Even before going to bed, that is, I've already said that between 9 to 11 o'clock also, you can give him some bedtime snack which is rich in both calorie and carbohydrate and protein, so that we can improve his nutritional level. And use hypercaloric disease-specific scientific supplements. That is very, very important. You can use this. It's very safe and very easy to prepare also. So many nutrition supplements are available in the market now. So you can use the hepatic supplements, or you can use some kind of peptide-based supplement. I cannot mention any brand or name here. So you can use any peptide based, or you can use any hepatic based nutrition supplements, because most of the hepatic formulas are hypercaloric only. Isocaloric is they yield 1 calorie per 1 ml. That is 1 ml of the solution gives 1 kilocalorie. Hypercaloric is they provide about 1.5 to 2 kilocalorie per ml. So even in case of fluid restriction, for example, one cirrhotic patient is there and the patient is having severe ascites and his fluid has been reduced, and we can give him only 1000 ml per day. That is only 1 liter per day, and he is not able to take orally, and there is no other go. He has to go for only tube feeding or liquid feed. What we can do is we can give him. We can use this liquid formulas, scientific formulas, which provides almost, which covers his nutritional requirement. For example, this hypercaloric 2 calorie per ml or 1 calorie per ml provides him a better calorie. Next slide, please. So this is about the cirrhotic liver. Next is hepatic encephalopathy. So what is hepatic encephalopathy? So these toxins are accumulated in the brain. Generally, during the liver dysfunction, the toxins are not excreted via the liver. So these toxins get circulated in the blood and it reaches the brain. So it damages the brain, leading to some physical and psychological symptoms. So in severe cases, the patient may lose his consciousness and may go to coma also. So what are the manifestations of hepatic encephalopathy? So confusion is there, fatigue, bad breath, irritability, slurred speech, loss of consciousness is the last stage which is seen in the hepatic encephalopathy patient. Next slide, please. Next slide, please. So please see the calorie content. 25 to 35 kilocalorie per kg body weight is recommended for this hepatic encephalopathy patient. And again the same, the patient is conscious, if he is able to take normal food, well and good, he can take orally. If the patient is not conscious and he requires some kind of tube feeding, then we can go for scientific based formula accordingly. And then there is no need to restrict the protein. That is very, very important. So initially you can start with 0.5 gram of kg per day, 0.5 gram of protein per kg per day, and then you can increase up till 1.5 gram of protein per kg per day can be given. So there is no restriction of protein. In fact, you can give him BCAA, branch chain amino acid. So this helps to reduces the symptoms associated with hepatic encephalopathy. And you can give him high biological value protein and strictly avoid red meat because it is rich in fat. And in case of fat, it should be less. It should be around 25% from the total body weight. And in case of carbohydrate, only complex carbohydrates are recommended, and avoid simpler sugars. Alcohol, in case of alcohol induces or increases hepatic encephalopathy, so strictly avoid alcohol, even though few recommendations or suggest it's better to avoid alcohol in case of hepatic encephalopathy patients. And fiber is very, very important. About 25 to 45 grams of fiber is recommended in case of hepatic encephalopathy patient because fiber has anti-encephalopathy effect, because this fiber helps to reduces the bowel transit time and increases the ammonia elimination. It helps to excrete the ammonia in the feces. Thus, fiber is very much important in case of hepatic encephalopathy. Next slide, please. So, probiotics. In case of probiotics, many studies show that probiotics reduces the MELD stores, MELD. And then manganese encephalopathy. Even in case of hepatic encephalopathy, manganese is also gets accumulated, leading to manganese encephalopathy. So can sometimes restrict the manganese. And then zinc, because you can supplement them with zinc. Already the patient is anorexic. To improve their appetite, you can give him zinc supplementation. And then strictly there is no protein restriction, and BCAA supplementation is very much recommended for hepatic encephalopathy patient. MELD cirrhosis. This is model for end-stage liver disease. Model for end-stage liver diseases. Next. So the next stage is hepatitis. So hepatitis, it is in simpler term is inflammation. ITIS is always inflammation. So it's an inflammation of the liver. Okay, it's a simpler term, inflammation of the liver. What is inflammation? Inflammation is swelling. So in simpler term of inflammation is when it's a swelling of the liver. So this hepatitis or inflammation might be due to two reasons. One is due to viral infection and second is due to alcohol. Okay. So, in such cases, it's very important to reduce the alcohol intake or totally stop the alcohol intake. The hepatitis is of two types. It is acute hepatitis and chronic hepatitis. So, the manifestations of hepatitis are joint pain, muscle pain, fever, headache, and jaundice. All these are the common manifestations of hepatitis. Next slide, please. So these are the classification or types of hepatitis. So hepatitis A is caused due to hepatitis A virus, and this is occurred due to oral fecal oral routes. That is due to consumption of contaminated food and water. And hepatitis B is due to B virus, and this occurs due to unprotected sex and by sharing the needles to inject the drugs. And hepatitis C is due to hepatitis C virus, which is usually transmitted through blood-to-blood contact. And alcoholic hepatitis, as the name implies, this is due to alcohol consumption, excess of alcohol consumption. And hepatitis D, this is due to hepatitis B virus. So this is present in people who are already affected or infected with hepatitis B. And then hepatitis C, which is due to hepatitis E virus, and this is again due to fecal oral route, which is due to consumption of contaminated food and water. And autoimmune hepatitis, in this case, the white blood cells of the body attacks the liver. An individual's his or her own white blood cells affect or attack the liver, leading to autoimmune hepatitis. Next slide, please. So coming to the medical nutrition therapy, since the liver, in this case, you can give him high calorie and high protein once again. So energy is 35 to 40 kilocalorie per kilogram per day, and protein is 1.2 to 1.5 kilocalorie. So as I said, here if the patient is not taking any oral food, then we can go for tube feeding, but PEG is not recommended. Percutaneous endoscopic gastrostomy is not recommended in this case. And you can give him whole protein formula and high energy formula in case of ascites. Next. And one more important in this is iron overload is seen in hepatic encephalopathy. So what we can do is restrict the iron supplement, avoid iron supplement and vitamin C supplement. But you can give them normal iron rich foods and normal vitamin C rich foods. But you must only need to avoid the iron supplements and vitamin C supplements due to iron overload in case of hepatitis. Next slide, please. So these are the foods to be avoided. What are the foods? So alcohol is the main culprit for any kind of liver disease. Avoid alcohol. Then all the hot spices, foods, refined products, and then all the fried food, junk food, processed foods, or excess of drugs in case of all the painkillers, paracetamol, all these in excess has to be avoided. So all these drugs or the medication must be taken only with the prescription of the doctors. Self-medication has to be avoided. So all these self-medication may leads to intoxication of the drugs. Next is what are the foods to be included? So you can take all the seasonally, locally, freshly available foods and vegetables, legumes, fish, and all the whole grains. And drink plenty of water because water helps to excrete the toxins out of the body. Next slide, please. Ma'am, do we have time, ma'am?
Yes, ma'am. Yes, ma'am. We can continue, ma'am. If you're okay, we can continue, ma'am.
Okay. So next, let's see about the Wilson disease. So Wilson disease is an autosomal recessive disorder. So generally, in case of copper metabolism, we used to see two conditions. So one is copper deficiency and copper intoxication or excess of copper toxicity. So copper deficiency, we know that Winky-Kinky syndrome is one of the conditions due to copper deficiency, but this is in case of copper accumulation or excess of abnormal copper accumulation in the liver. Generally, copper gets accumulated in two organs, one in brain and one in liver. But here, Wilson disease is accumulation of copper in the liver. So how can we diagnose this Wilson disease? Generally, ophthalmologist can diagnose Wilson disease because by using this slit lamp, ophthalmologist check for Kayser-Fleischer ring, that is a small ring-like structure in the cornea. So by using the slit lamp, they may find this KF ring and they will diagnose as Wilson disease. Another diagnostic methods are biochemical parameters such as serum, ceruloplasmin is tested, and then urinary copper excretion is tested, and liver biopsy is also used to check the Wilson disease. Next slide, please. So when coming to the intervention, so the only intervention is chelation therapy. What is chelation therapy? Chelation therapy is a medical procedure where chelating agent is given to the patient. So this chelating agent will remove or absorb the excess of the heavy metals from the body. Okay. So during this therapy is not a short-term therapy. This chelating therapy is not a short-term therapy. It's mostly a long-term therapy. So in the first year of the chelating therapy, the patients are strictly recommended to not to take copper-rich foods for up till the first year. And after the first year treatment is over, you can gradually start with the copper-rich foods. But initially for the first year, strictly there is no copper-rich food is allowed. So a diet low in copper with added supplementation of vitamin E and zinc is supplemented. But we must check. There is a zinc, there is an interaction in case of zinc and the chelating agent. For example, chelating agent like penicillin is given, zinc hinders the work of the chelating agent. So in such cases, you must give zinc only after 2 hours after taking the chelating agent. So once a patient is taking chelating agent in the morning 10 o'clock, you can give zinc rich foods or any kind of zinc supplement after 2 hours after taking the chelating agent therapy. That is, if the patient is taking penicillin at 10 o'clock, you can give the patient zinc supplement or zinc rich food only by 12 o'clock. So 2 hours gap is very important to prevent the interaction between the chelating agent and the zinc. So you must it's very important ensure that drinking water should contain less than 0.1 milligram of copper per liter. So all the copper and brass pipes and then which is used for the water supply are also rich in copper, and it should be avoided. It should be replaced with some plastic or some other type of metals or whatever. It has to be replaced. And then for example, if the patient is taking any tube feeding, just ensure that most of the tube formula feeds, most of the supplements are rich in copper. So when you are giving a tube feeding to this Wilson disease patient, just check the label whether that particular brand or supplement is rich in copper. And then next slide, please. Next slide. These are the do's and don'ts. So, as I said, check the food labels for the copper content, and then dairy products and whey products are very good source of protein, and they do not rich in copper. And one more thing is when you are reducing your copper intake, even you are restricting your protein intake, because most of the copper-rich foods are also rich in protein, and most of the protein-rich food contain copper. So when you are restricting your copper, unknowingly you are restricting your protein also, which may lead to protein deficiency. So it's always good to go for dairy products and whey protein to meet your protein level as well as to reduce as well as you're reducing your copper content. So what are the don'ts? So people with Wilson disease should not take any vitamin mineral supplement that contain copper. For example, when the patient is taking a multivitamin tablet. So this multivitamin tablet may contain some copper also. So this is not at all recommended. And then do not use any copper storage containers or water bottles or any cooking utensils with copper, so that this may increase your copper content. And the foods rich in copper are shellfish, seeds, nuts, organ meats, wheat bread, mushroom, chocolates, whole grain products, sweet potatoes are to be avoided. Next slide, please. So the last one is the transplantation, MNT in liver transplantation. So the main aim or goal from liver transplantation is to prevent the nutrient and muscle depletion and to carry any vitamin mineral deficiency to present in order to minimize the risk of infection. So there are three major goals. That is, you're going to prevent the nutrient deficiency. Prevent nutrient deficiency, prevent all the vitamin mineral deficiency, minimize the infection, and reduce the muscle depletion. So these are the goals we have to plan before taking up medical nutrition therapy for a liver transplantation patients. So you cannot overfeed the patient because excessive feeding may lead to diarrhea, bloating and vomiting. So once the patient has been decided for transplantation, it is very important to start up the nutrition therapy or good nutrition before 10 to 14 days of the day of surgery, because most of the liver transplantation surgeries are elective surgeries. So once the date has been fixed, you can start up the nutritional support before 10 to 14 days. So most of the liver patients are very malnourished. You cannot force the patient or overfeed the patient. You can only gradually increase the nutritional status of the patient by using a concentrated foodstuffs. Next slide, please. Next slide, please. So this is the nutritional requirement. So as I said, you must start 10 to 14 days in case of pre-transplantation. Start before 10 to 14 days of the 10 to 14 days of the surgery. In case of energy, about 30 to 35 kilocalories is generally prescribed, and in case of obese, about 25 kilocalories is prescribed. And in case of protein, 1.2 to 1.5 gram is recommended. And BCAA, branched-chain amino acid, is very, very, very important. And plant-based protein is recommended because it is rich in protein, rich in fiber, rich in antioxidants, and low fat. So it's a reason why we recommend plant-based protein. And if the patient is not taking oral feed, we can go for tube feeding. And then carbohydrates is 50 to 60%, and among them, more than 60% should come from complex carbohydrate. Avoid the refined sugars, fat. Avoid all the saturated trans fatty acids. MCT is recommended because in liver dysfunction, fat is not absorbed properly, so MCT is recommended. Sodium is 2 to 3 grams per day is recommended. All the vitamins and minerals are to be supplemented, and small frequent feeds can be given. You can give some immune nutrients because the patient has to undergo a major surgery. You can improve his immune system. So you can give him small frequent feeds and immune boosting foodstuffs, etc. And in case of post-transplantation, early feeding is recommended. So after liver transplantation, normal food or enteral nutrition should be initiated 12 to 24 hours post-operatively to reduce the infection rate. So the recent studies shows that early nutrition intervention has to be recommended to prevent the infection. So once the patient has come from the surgery, after 24 hours, you can 12 to 24 hours, based on the condition of the patient, you can start the feeding. So initially you can start with the clear liquid and then full fluids. By the day of 1 or 2, you can go with the normal feeds, but do not overfeed the patient. Give him small, frequent, gradual food, gradually increase his calorie, give him small and frequent meals. You can give him in small quantities initially, and then gradually you can increase his quantity, and then give him 30 to 35 kilocalorie per kg body weight, and protein is the same 1.2 to 1.5. That is, you're going to give him high protein diet. Why you're giving high protein is already the muscle depletion is there, and then to prevent the infection, to support the wound healing, everything you're going to give him a high protein diet. So the route is either oral or NG feed, nasogastric, nasojejunostomy, or anything can be, catheter jejunostomy also can be given. In case of sodium, we can give them up to 3 grams per day initially, and later on when ascites is when the ascites gets reduced, when the patient is normal, then you can give him normal sodium. But in the initial stage of post-transplantation, 3 grams per day of sodium is recommended. And then you can supplement with vitamin B12, calcium, phosphorus, and all the other nutrients. So whole protein or peptide-based formula is also recommended. Next slide, please. So coming to the conclusion, so these are the points has to be remembered before you support before you give a nutrition support to a liver patient. So the first very important point is nutrition assessment. So this is very, very, very important. So without nutrition assessment, medical nutrition therapy is incomplete. So please mind that nutrition assessment is very important. So take up the nutrition assessment, and then coming to the therapy, adequate calories. Only calorie is reduced only in case of obese or overweight patient. Otherwise, in case of liver patients, adequate calories is recommended. Adequate calories in the sense it's a normal recommended dietary allowance is given. No protein restriction at all. Protein is restricted only in case of hepatorenal case. Otherwise, there is no protein restriction in liver disease. And then sodium and fluid restriction is given only in case of ascites. Because the sodium restriction should not go less than 60 mmol. Ensure that, because less than 60 mmol of sodium may reduce the palatability of the food, which again in turn makes the patient to be malnourished. And then you can give the patient with multivitamin, mineral supplements accordingly. Oral nutrition supplement can be given as an additional nutrition support. So if the patient is not able to take orally, then enteral or parenteral feeds is recommended. So all these points has to be taken down before carrying out nutrition therapy for our liver patients. Thank you all. Any queries?
Thank you, ma'am. Participants, please drop your queries in the chat box.
think it's clear, ma'am. It's really informative. Ma'am, it's there is a question. Will toxin of food like aflatoxin can also be a risk of CL? Can the patient have groundnuts included in their diet?
Sorry, aflatoxins? See,
Will toxin of food like
toxins
aflatoxin?
may lead to food toxins like aflatoxins may lead to liver dysfunction. I mean, not in the advanced stage, but earlier stages. Because all these toxins gets accumulated in the liver. So many of the food toxins may lead to hepatitis. Toxins are in many forms, not only not only artificial form. Many toxins are present in the food. So all these the food colorings, preservatives, and then all the artificial foodstuffs. Even synthetic coloring, synthetic flavors, synthetic preservatives. All these are toxins only. So you must take them in. You must check the label. You must take in a very, very limited quantity. Otherwise, it's better to avoid. So all these are a form of toxins only. Even seafoods. Many seafoods are also contains mercury. So even mercury and lead is also a form of toxins. So all these may affect the liver.
Ma'am, recommended copper level, ma'am.
See, generally you must. I'm not exactly sure with the RDA, but for in case of Wilson, it has to be less than 1 milligram.
Okay, ma'am.
MELD is model for end-stage liver disease, ma'am. It is a score actually. This MELD score is generally used for the hospitalized liver patients, ma'am. This is similar to quality of life, QOL scores.
Thank you, ma'am, for an elaborative, informative talk. You have enlightened about fatty liver, NAFLD, hypercalorie diet, DASH diet, internal and parental nutrition, NASH and etiology for liver cirrhosis, hepatitis and liver transplantation, and more. Thank you once again, ma'am.
Thank you all. Thank you very much for the opportunity, ma'am. And dear students, thank you all and best wishes.
The best and most beautiful things in the world can't be seen or even touched. They must be filled with the heart. On behalf of the DORAI Foundation and from the Department of Nutrition, Food Service Management and Dietetics, from Srimati Devkunwar, Nana Albert Vaishnav College for Women, Krompet, I extend my gratitude to our distinguished chief guest, Dr. V. Bhavani ma'am, to take out her time from her busy schedule to grace the event. Thank you, ma'am, for the excellent enlightening information on liver cirrhosis. Dear participants, stay tuned with us to connect with next interesting scientific talk on nutrition in dengue and malaria by Miss Sindhulata AP, registered dietitian nutritionist on 20th of this month at 6:30 p.m. And don't miss to explore fun-filled quiz activity on today's topic, nutrition in liver cirrhosis, tomorrow at 6:30 p.m. Once again, I thank one and all present here. This is DORAI Foundation and Team NFSMD signing off.